So MS39 tips for advanced users. We thought with Francesco to do that, to follow the basics laid down by Mazen. And I think these are not comprehensive tips. There are millions of tips probably. And nobody of us can be considered advanced user. This is something that we keep learning, and this field keeps evolving. But I thought I would share some vital tips that helped me a lot all along. So noise is good in certain scenarios. Not everything that is HD or average is really nice. It looks nice, but it will conceal a lot of information. And I can't think more of the ICL. A lot of time in certain situations, take a look here, it's not always clear. I mean, it depends also on the, especially if it's first day post-op, second day. But if you do a raw scan, non-average, you can detect the surface much better. Because here I want this noise. I want to see the noise. Otherwise, if it gets averaged, little movements, it will get canceled. So either it gets summated or it gets canceled. Another example would be actually this. A patient was referred to me from a colleague, 3 days out, has a focal thickening in her cornea. And the technician just does the scan, which is an average scan, and you can't see much. But again, if you go ahead and perform a raw scan, you can easily see that there is an endothelial detachment, small endothelial detachment. And again, here, the same concept. Endothelium is such a thin layer, and if it gets average, it might very well get canceled, not summated, and you will miss these details. If you look here at post-DMAC surgery, there is a part of the cornea which is still swollen. Is the graft attached or not? And more importantly, is it in the right orientation or the wrong orientation? And again, a raw scan is the best scan for me to tell me what's going on. I'm really looking for noise here. So again, this concept that we need to see a smooth, nice image is not always nice. This is like looking at axial versus tangential. See, I got the attention of Cynthia here, okay? So axial, smoothing out things, you think things are nice. You look at the tangential, it's kind of archaic, a lot of details. You don't want to look at it, but actually, this is the one that shows you the most details in certain situations. Distortion is sometimes good. That's why I look always at anamorphic sections. And this is really what sets the MS39 apart from all other OCTs. Now, take a look here. You have you can easily tell this is a post-LASIK case, long time ago, keratome, and here's the tip. You always look at the interface as being hyper-reflective, but if it's been some time, the interface, especially in the center, not at the periphery, is hypo-reflective. So look at that. But you can easily tell with the anamorphic, everything is condensed and everything is aligned to the first tear film. You can easily tell first, you can see Bowman's layer, so this patient hasn't had any surface treatment, and you can see that the cut, even though it's almost planar, but it's not perfectly planar, you can see the hyporeflective area in the middle. And it's you have an idea what it is. And by the way, and I think you've heard me many times stress on this, but I'm going to discuss it quickly here again, that OCT always will look at segmental tomography. We forget what power we have when we do this tomography with MS39, because everything is integrated. So always look at OCT for history, even if the patient tells you never had any surgery before. You'll discover sometimes patients having LASIK, PRK over LASIK, and the patient is like, oh yeah, 20 years ago, sometimes low myopia. You can't really tell when you look at topography. So again, here, you can really see here a flap with a little bit of hyporeflectivity in the center, but you can easily tell on anamorphic that the flap is actually meniscal. You can see how it just curves around. You can see Bowman's layer as well. This is a mechanical keratome. Now, how about this one? You can see a really nice flap here, but if you look at anamorphic, it's aligned with the tear film. It's a perfectly planar flap with square edges. This is a femtosecond LASIK. And then, of course, Bowman's layer is still there. Now, take a look here. Again, and on anamorphic, you can't see the flap, But you can see also Bowman's layer. This is a PRK. The epithelium is thicker than the periphery. This is a myopic PRK. Let's take a look here. Again, you can see some details. And this is Bowman's layer, but it disappears right after about 3 millimeter. That's actually hyperopic PRK because the center is spared, so Bowman's layer is there, but the bilaminar layer, is lost. And here you can't see it, but on anamorphic, and you can see this layer. You have Bowman's layer in the middle, but it disappears right away, and you see a meniscal flap right there. That's actually a PRK done, a hyperopic PRK, because you can see the Bowman's layer in the middle, a hyperopic PRK done over a mechanical LASIK. So a lot of information that you might miss if you don't stop, look at your OCT, shift to anamorphic, instead of just taking a look at your tomography. And that's the advantage. And this is always done on the routine scan. In my clinic, every single patient gets an MS39, and then we see them on the slit lamp. So this is like a digital slit lamp. They have it anytime they come in the clinic. Now, beware of the refractive index. So we were just in the first session discussing about biometry, and IOL master frequently, and there are many studies in JRS published and in JCRS as well, that it will underestimate the anterior chamber in patients with PCIOL. But this is more important if you have a hyperopic ICL because of the thickness. And again here, the IOL master showed an ACD of 2.46 because it just measured the top part of the lens with the CCT, of course. And even the MS39 just showed you that it's 2.46. But you have the power on the MS39 to go ahead and calculate. But if you want to do so, the MS39 has this really great scale that you can get the index of fracture. Remember, OCT is just a physical distance happening. So you want the machine does not extrapolate what kind of material is in there. It does for the cornea based on segmentation, but you might have all types of different implants in there. If you know the type, if it's a Collamer, if it's PMMA, you can select right from the left-hand side and then go ahead and measure and get an accurate total measurement. This is a patient who had an early cataract because of the hyperopic ICL almost touching, and I wanted to change. Same thing with PMMA or all types of lenses. So you can know the index and calculate the right thickness of that area. Another tip is that check all the section. Just don't look at one. You'll be surprised what you can find. So skepticism is good. Look at raw data. So in here, a patient who was ready for trans-PRK. And of course, trans-PRK, you have to always look at the epithelium. This is the epithelium 74 micron, and that's unusual, right? It's 55 usually, plus or minus a standard deviation that is really small. This is the cornea thickness, 590. Let's take a look at the fellow eye, and it's 58 microns. What are the odds? So we always do 3 measurements. I take a look at the other measurement. It's 70 microns, again, at 583. Third measurement's even worse, 78, 592. So I take the patient and say, this happens sometimes because the patient will be over-tearing. And the MS39, like many, but not all OCTs, will recognize the tear film as part of the cornea thickness, as part of the epithelium. So we'll give you a thicker epithelium. You have to make sure that the technicians are really aware of that, and then don't try sometimes to open the eye all when the patient is tearing. So I go ahead and do the measurement myself. But before that, I look at the anamorphic. And again, look at the raw data. And you can see that's interesting. Later, maybe Francesco can explain that to me, but I assume maybe this is a lipid layer that is forming right there and giving an extra thickness. It's like a bilaminar layer, like Bowman's layer, is very interestingly. So when I go ahead and repeat the measurements, then I get a 58 micron, just like similar in the other eye. And even the cornea thickness decreases from 590 to 574. So understanding your technology will make you understand these cases that will actually make or break the surgery. Otherwise, I would have programmed 78 microns and completely got something else. And again, I actually let the patient for about a week or 2 on lubrication, because I believe, even though now I don't see this anymore, but still you can see this hyperreflective tear film right on top of the epithelium. So again, another one is OCT section. Always be skeptical of your data, even if your machine is amazing, because with this patient with very advanced keratoconus, the MS39 shows 54 microns in here. But again, if this is so much away, don't trust segmentation. Segmentation is based on AI, and don't trust AI when you don't went at the periphery of your spectrum, because you don't have enough training data for this. And look at the raw data, and these are the raw data, and you can see a whopping 132 microns instead of 54 microns. And then what remains underneath it, it's 204. So if you're doing cross-linking, now you have rethink your algorithm and which algorithm you get a try, the sub 400 or the M or whatever, but this changes completely your decision. OCT sections, as I said, don't look at one, always rotate and look at everything. This is a flap that if you're thinking to relift because the patient did LASIK somewhere else and you're thinking of relift, think twice, look at all the section, and this is the section 90 degrees away, and that's it, all right? So if you're thinking to relift the flap, think twice, because look, even here, the flap went in, that was a buttonhole before, and if you keep looking, there was also a PRK treatment on top because Bowman's layer is not there. We ended up doing transepithelial PRK for the patient. We kept the astigmatism. We treated only higher order aberration. This is first month. The epithelium is much more regular than all the acrobatics it was doing. And we have a flap segmentation that Francesco has promised us, and Gilda as well. So we're still waiting for the lawyers to finally give their final decision. It will be present on the MS39, plus all the previous history, LVC history, and everything for the patient. And again, look always deep. This is a retained lenticle, and after steroids, it disappears. So look at all the sections. And finally, quickly, and this is just a few slides to end, always look at all the maps and look at the Gaussian maps. Look at what happened here. This is the axial. You see how far away? Look at the tangential and look at the Gaussian. And you can see the elephant is the room is the axial, way out. And it will give you a wrong idea where the cone is. You can compare them all together and you can see. So always do not use axial, okay? And even this gets worse if you do subtraction topography because they will subtract. So double error, double whammy. Don't do subtraction axial. And you can see it a lot in cares or everything. Always use tangential if you want to think of the refraction, or Gaussian even better. And this is how Gaussian in early keratoconus, you can see a very nice bow tie, but look at the Gaussian right there. So it gives you even a higher input. And if you look at all these, if you look at the ablation is damped down to the Gaussian, not even the tangential, the laser ablation, because the laser thinks always where the cone is and going to put their pulses on the cone. So it tells you where the real cone is. So that's it. So with these tips, hopefully this should arm you with deeper insights. Thank you so much.